Yes, sir. We are live on YouTube now. Welcome to the Indian Arthroscopy Society Academic Corner. This is a webinar series we are conducting every monthly. For the month of October, we have expert talk and also two case presentations as usual. We are being moderated by our eminent surgeons and panelist, Dr. Harish Chandran sir from Kerala and Dr. Vivek Pandey sir from Karnataka. I am handing over the session to Harish Chandran sir and Vivek Pandey sir to carry on from here. Over to you, sir. Please can start the session, sir.
Yeah, hi. Good evening, Vivek. Good evening.
Good evening, boss. Good evening.
Good evening. Yeah.
Sorry.
Sorry.
I told Naresh that we have some emergency meeting of some stem cell people. They have come from somewhere. So they asked me to join. So I said, okay, today I will. Then I suddenly realized, oh God. Anyway, I'll be there till 8:30 certainly.
Yeah,
Great,
okay.
sir. Thank you, sir.
So we have a couple of talks lined up for the IS Academic Corner. And
Yes, I didn't want to miss the master's talk, Jacob
yes,
Burgess, boss.
yes, Dr. Jacob
The
Burgess
meniscus
talk
mantra.
on,
I said
meniscus mantra,
before I
yes.
go for these meetings, I must have the mantra.
And then we have a case presentation by Dr. Nandan Rao on KD3 knee dislocations, two-stage repair with sparing approach. And the second case presentation by Dr. Hari Prakash on all-inside Faisal sparing ACL. Over to you, sir. Jacob Burgess, sir. Since you have a flight to catch up, I think you can share your screen and we'll start the talk.
Have you got my screen?
Yes, sir. We are able to see your screen.
Yeah.
Yes, sir.
Yes.
Correct.
Right. Thank you, Naresh, Harish, and
Thank you,
Vivek.
sir.
Thank you for inviting me here. And what I expect, what I've done over the last 20 years, and I hope I can share some of the things, and probably some things may be controversial. So you could stop me or ask me a few questions at the end of the meeting. And let me get started. I'm not really sure what best to do about meniscus. I know one clear thing, and removing the meniscus is bad news. What do we do? So we all started off saying that if you are older, you remove the meniscus. It's not true anymore. We said white had worse results. Yes, worse results, but even some whites heal. People said degenerative tests do worse than traumatic tests. It's not true anymore. We all know there is a failure rate where you could call it from 10 to 30%, depending on the type of tear or where the tear, which meniscus it is. And we're very clear that lateral meniscus, for whatever reason, they heal most likely in any situation. And if you remove the lateral meniscus, you're in it's bad news for the knee. And anything posterior to the equator, the central part of the knee, for me, is the most important thing. You need to retain whatever it is at the back of the knee to add to the stability. Now, why did we still start doing meniscectomies? Because it's cheap, it's quick, you can get them to rehab quickly, got good short-term results. And of course, you had this unpredictable healing rates. And I had patients who, in the early part of my career in 2000 come and got angry with me for having a re-tear or a failed tear. But remember, if you start removing it, you also have the spontaneous insufficiency fractures and SPONG, sometimes even after repair. So you need to be careful about that. And of course, you have this high rate of osteoarthritis progression. Now, meniscus has got a whole lot of function, other than being a transducer, changing potential energy to kinetic energy, its congruency, stability, shock absorption, lubrication, and giving us even proprioception. So I keep telling that the meniscus talks to your brain because it's got a lot of proprioceptive fibers there, especially at the back and the peripheries, and that's why some of the people are better sportsmen than me. And importantly, histologically, meniscus is much more complex than the cartilage. We thought cartilage, we were the first guys to culture cells and put in the knees and other places, but meniscus is a different game. It's not that easy. It has 72% water. There's more water at the posterior half than the anterior half or the posterior horn. You have more of type 1 collagen, more so in the red area, less in and more type 2 in the white area, and around cells type 4. And you have all this negatively charged glycosaminoglycan, all the different types from aggregant to lubricants, which absorb lubricant, which absorbs water to make the meniscus more turgid. And often this molecule lubricant is going to be the big game changer, I think, in the next few years. We probably, instead of pushing on this hyaluronic acid, which I think has already gone into disrepute, you might be coming up with lubricant molecules to inject into the knee. And of course, you have a little bit of glycoproteins and elastin. Now, if you look at it as an organ, you don't remove you don't remove part of the heart. So you want to retain everything. It has these micro canals from the center to the periphery, which communicate, which pass fluid both through diffusion and through this canal. So it goes out and in, and the nutrition is there for even the white area from the fluid inside the knee, even there is no blood vessels. And we already know about the Pacini corpus and the Ruffini bodies, which is all around the knee or around the meniscus. We all had this red, white, and red zone. We also know that there are different cells. They have a fibrochondrocyte to a chondrocyte in the meniscus, and what we call it as a meniscocyte, which produces and makes these glycosaminoglycans in different, and it keeps changing in different years, and depending on the loading, the glycosaminoglycan concentration keeps changing in the meniscus, making it more water absorbent and also more resistant to stress. Way back in 2014, Frank Noyes clearly showed us that even in the hypovascular area, you can get some healing, even sometimes in white on white. And this is what we do. As soon as you start removing a meniscus, this is a patient 3 months after had meniscectomy, partial meniscectomy, and coming with arthritis in 3 months' time, because the peak adduction moment increases. There are some chemical changes. You're going to put in all sort of chemicals into the knee, which is going to cause further degradation to the rest of the knee. So you can see his MRI in 6 months, you've got a chondral defect, you've got a big spong there, and that's the beginning of end of knee. So we want to retain the meniscus for whatever reason. And of course, we all know the longer the time period after the meniscus is out, you are going to start getting arthritis. So because you increase the load into the knee, we also have increased production of metalloproteinases, where you want to remove it arthroscopically or wash it out, or you want to use drugs to reduce it, or to reduce further degradation of the knee. So why do we still do? Because we still do meniscectomy, because there are a limited number of long-term studies with meniscal repair. But we clearly know that if you repair, you got a better score. There's definitely less degeneration in the partial meniscectomy. And even in complex tears, repair scores better in meniscectomy. That's clearly proven. So all what I'm trying to say, do not always try to preserve meniscus. So even if you have to do a meniscectomy after meniscal repair, it's very infrequent. Even then, the results are better. So of course, we know that if you do it along with the ACL, the results are better. And even in older patients, and the results are fine. And of course, you have high volume things have better published results. Even if you failed, what you remove after that it won't be the entire failed meniscus, only part of the meniscus may need to be removed. And so probably it still can reduce the chance of arthritis. Now, we know clearly medial meniscus has a higher failure rate than lateral meniscus. That's probably because on the medial meniscus, you have the smaller vessel to supply it, unlike the lateral meniscus, which has got a larger vessel. And also that the lateral meniscus have to move by about 2 centimeters in flexion. You can see it goes over the back of the knee. And you can see in the front here, it goes about 2 centimeters. So it's probably mobile, and so therefore less tension on the suture side as the entire meniscus moves. And that may be the reason why we have worse results of the meniscus, both the blood supply and the mechanical reason. Now, clearly, if it's below 40 or above 40, the results are the same. This is cleared by the Steinman's clinic. Even in chronic injuries, I've had 2-year-old locked meniscus with a flattened lock, which is healed, and in 40-year-old people. So chronic tears also can heal. So don't have to remove because it's older. Now, as far as indications of repair, we all know what the repairs are, but we want to extend the indications for cleavage tears. We don't want to take it off, one half of it, and you want to repair that too. Radial tears definitely do not remove, because if you remove the radial tears, that's the beginning of the end of knee. Even in oblique tears or paraoblique tears, you can start repairing, and once you start repairing, you probably realize that you need to remove very little of the meniscus. I definitely do all red, white, and sometimes even at white, white. Now, what is important is how you prepare the site. You need to have the good surgical technique, and of course, you have to rehab them right. Now, how do you prepare them? The easiest way is we used to abrade the surface. We used to put needles from outside in to cause vascular growth from inside out. We used to inject fibrin clot. That's how we all started. Now we use platelet-rich fibrin, which is easier to transport it into the tear. We started turning a piece of synovial flap into the tear. Then we realized that when you start moving it, it might tear off. Of course, there are people who use fibrin sealant with all sort of growth factors. Now, basically, there are 3 types. inside out is the gold standard, nothing to beat it. It is the most stable part of the tear, type of repair rather than any all inside or outside in. So it's important that we probably use a little bit of everything mixed depending on where your site is. That posterior, probably you want all inside to avoid damage to the vessel, especially on the lateral side. But otherwise, inside out, we can put more, they're cheaper. That's definitely the gold standard. Now, we have these zone-specific cannulas, which you can redirect from even from the back to the front. So if you use those bend spoons or spades at the back, you could sometimes even get the spoon-specific cannulas, or even the micro lasso, which you use for the wrist, can be used sometimes the meniscus to direct it. And using these needles with thread are the best for me. So it is definitely inside out is great for large tears. We have all the suture, all inside materials. We're using PEEK and all suture materials. The issues with these, some of them migrate back into the joint. I've had situations where I had a rail track after 9 months with the PEEK migrating back into the, so I'm a bit more wary of the PEEK, especially I don't put many PEEK unless I have very good capsule at the back. And so we have started going on to all sutures many a time, but we have problems with that too. But at least if it migrates back, it doesn't cause any problems. Now, next is, do you use absorbable or non-absorbable? We all started with absorbable sutures, but we know that within 6 weeks they go. And that's probably why we had this earlier failure rates. So now we use non-absorbable sutures. And if you go back and you see these are covered by synovial tissue, and you don't see any markings in the cartilage due to the non-absorbable sutures. And these days we use tapes which are flatter, so it doesn't get and cause abrade the surface. And also it gives you longer fixation for the cells to heal the meniscus and remodel it. There are papers to say that absorbable sutures are better. And now, of course, there are people starting to coat these with some sort of growth factors to hopefully by the time it gets absorbed, you can get blood supply or fibroblasts to grow into it and bridge. And I'm not too sure the strength, if you have a fully vascularized meniscus, is any better, or it may be dangerous. Now, the gold standard is inside. Henning showed us how to do it. We have the Henning retractors. So we need to have a safety incision. Generally, we go posterior to superficial MCL, and we want to go more inferior than superior so we can cast the needle out. So somebody should make the safety incision, use your scope, see the saphenous vein so you can avoid the saphenous nerve, and put a spade or a bend, a broad spoon there, and so your assistants can keep catching it. You want to see the vein, so if you see the nerve, you can definitely go above or below it. And we need to probably counsel the patient that we might need have some numbness. Sometimes when you start moving it aggressively, I had patients who had numbness after they start moving it after 90 degrees. And then sometimes you might have to go back and inject steroid or something like try and reduce the symptoms, but they might have some numbness. Now, inside approach, we said, now other thing, other than the safety incision, we clearly know that the vertical stitches are better than the horizontal stitches. The advantage of the inside approach is low cost. You can put multiple sutures. We said already about the neurovascular injury. Of course, this also increases the surgical time. Sometimes when you pass the needles, you could damage you could cause needle stick injuries, and you need an experienced assistant to cast the sutures and tie it so you can see the meniscus being reduced, and you don't want to over tighten it and cause it to flip. So there are various ways of suturing. We always said this vertical is better than horizontal. We want a broader tissue on the inside and a narrow tissue to the capsule. You've got good tissue to hold it. You want to use divergent sutures. If you find that the meniscus after one suturing starts lifting up, you want the next suture, you want to load it down so you can correct the fold of the sutures. So you need to keep changing. So it's important that you look from inside when somebody is tying it from outside. You want to get a good approximation because we don't want synovial fluid to go into the tear and cause issues with that. Now look at this sort of bat test. Look at this tear. This is a 45-year-old chap with a complex tear, radial and radial and horizontal tear with already OA due to tear. It's a 45-year-old chap who want to reduce weight. You could see that if you just do the hashtag sutures. So what you do is you put 2 vertical sutures on either side, because otherwise if you tie just horizontal sutures, it's going to cut through, and then use that suture so that it doesn't cut through the tissue. You can see that here I used 2 vertical sutures on either side, and then on either side of the meniscus, and then put 2 or 3 horizontal sutures to approximate it. And then, of course, we try to augment all these complex degenerative tissues. If you start shaving this off, that's the beginning of the end of the knee. So you can see the next slide here. The next slide. The same patient, and I came back at 6 weeks for ACI. You can see one of the sutures come through. I cut through, the meniscus more or less healed. I've just cut that one of the sutures which is tied, and we are going for ACI. You could see that even the white area is healed, and this only at 6 weeks. So you'll be surprised to see this. Provided the patient understands there's a failure rate, you got informed patients these days, we can go and repair all these complex tears, even if it doesn't look too good. So similarly, if you have vertical sutures, but the tissue is bad because people come too late, you could put a horizontal suture like this first. So this, the black is a tear. You could put a horizontal sutures and use the vertical sutures around the horizontal sutures. It doesn't cut through and protect those bad tissue, and augment it with one of the other methods. I don't do this double bucket handle. I always remove the central one. We don't do that. But it's clearly important that more number of sutures. I generally put 2 sutures in every 1 centimeter. There is some papers out from Japan saying 8 mm one suture, but I tend to put 2. So at many a time I have 5, 6 sutures, inside out sutures, keeping the cost low, except for the back, use all inside sutures. So even complex tears like this, don't start shaving this off first. First start putting sutures, and then you can close the horizontal part lat. And if at all you need to shave after putting the sutures, and shave what is not held by the sutures, and don't shave in the beginning. That's a key. First repair and then start shaving. Now we have the root tears. We started early with different sutures, but clearly in the type 3, first put a suture at least on the bucket handle before you start pulling on the root. Otherwise, what happens, it gets pulled in and you can't reduce the bucket handle tear. And here, of course, these days, what we tend to do is we take the first suture more away from the midline, and then you can pull the sutures out. So you use a scorpion or water method. We were using all sort of suture lassos, shoulder suture lassos when we started. And then pulling with the first luggage tag, you can get the better suture the second. And all of us know how to reduce it into the tear. And you can actually visualize it with some of the newer techniques that you're drilling it down into place. You also need to curate out that area to have some vascular for it to heal. And then bucket handles, they're the best to heal. So you need to put more number of sutures, and I would put sometimes 8 to 9 or maybe even 10 sutures on bucket handles in white. Don't go and remove it even unless it's a very small white. And then we revascularize with one of the augmentation methods. So you can see here the double bucket handle sutures. I tend to put first sutures around, reduce it, and then generally trim that smaller bucket handle, because I'm not expecting cells to jump over 2 avascular areas. So after putting the sutures, reducing it, I decided which one to take. And you end up taking very little tissue. If I'd started taking this in the beginning, I would have taken out more tissue. So more volume of tissue is important, because finally you need a lot of glycogen stuff there before you start repairing. So first put sutures and then remove whatever you think one can't be removed. So this is again, Anna, one just to show that if you have a fold, I just want to go, if you have a fold of sutures when you tighten, so you can be lifted up, the next suture has to be down. And of course, all see that I'm lifting it up. So next suture has to be full down. Here I'm augmenting this with bone marrow injection just to improve my chance of healing. Anterior horn sutures, we were tying it to the capsule before. Now we know that because the lateral meniscus especially has to move so much back, if you pull it too tight to the capsule, you can't. So you want it closest in flexion, and you want it to be loose rather than tight it towards the capsule, because it's going to tear off. In posterior tears like ram lesions, you could use whichever method you want. We want to go through posterior, you can use suture lassos, you can use all inside, you can come from the back. Ram stitches are going through, a lot of people are finding newer methods to repair it, but it's important that anything at the back of the knee, even if it's complex tear, even if it's a vascular tear, I'm very aggressive on repairing it, because I think that's more important. It gives you stability and it does a lot more stuff. Nature has told that we need to repair these. Now, how do you augment the repair? You have biomechanical way of augmenting it. You have biological way of augmenting it. Biomechanical, you want to do centralization switch, especially when you have a root tears. Sometimes with a chronic tears, you will have to take a periosteal and go below the rim and elevate the meniscotibial ligament and remove sometimes the osteophyte with an and then put sutures. There's also this ketas circumferential fiber. I'll show I've not done that, but I would probably do that more in meniscal transplant. And of course, you want to augment your repair with one of the biological methods, either PRF, fibrin clot, or cells. Now, this is what I said. I tried this putting a suture anchor here and repairing it. I couldn't centralize it better. Now I actually put a suture and bring it right across and pull it like a root repair to bring it back in through the meniscus and put it back in. That way I can pull it back and centralize it. Otherwise, even if the root repair, it doesn't centralize when you go back to do an MRI. So you need to pull something back from the central area also, and not just root repair is needed if it's extruded. So if you have an extrusion, then we have a problem here, and that's when probably you need the circumferential sutures described by Kita, where you put suture anchors in the front, right, go across. You can either use suture lassos or scorpions, and this is more easier for me, at least in a meniscal transplant, because I can put the sutures around. I've not tried this. This is something very interesting because you're actually maintaining the hoop stresses and keeping the meniscus in place. So it's great. When I do a next time meniscal transplant, this is what I do, because sometimes I see extrusions after meniscal transplant. You need to augment the repair, so we are always vending it in the notch, but it's important that you want to vend it in the gutter. If you're in the posterior or peripherally, you can go to lateral medial gutter and make multiple venting holes. What I can do is then I don't move the knee for about a day or two so that the clot tracks into the tear, and I don't know how long the cells take to adhere, but depending on where the patient is from, I keep them for a day at least without moving so the clot settles there, or sometimes maybe more if they're very close by, so I can keep it for the cells to adhere and help me in healing it. Of course, we have this paper.
MSCs are created equally. Every MSC and every MSC procuring procedure has.
So what happens is we have papers getting these cells coming in to the place. I think there's a part of the recording. So we could augment the tears with meniscus. You can see this, of course, the BMAC is easy. The video here is we take cells from synovium from the. This is, I think, an augmentation from we're using BMAC into the tear. This is a radial tear which you're repairing. Here I'm using sutures there, and then we're augmenting with this BMAC here to increase the chance of it healing. And I'm not getting this 10 to 30% failure rate. I think I'm more than 2 to 3% failure rate. And even when I'm doing these, I think when I'm going back to remove part of the meniscus is healed, so I remove less tissue. This is a situation in a horizontal tear. You can see that we take synovium from the suprapatellar pouch, remove the fat, take a suture with it, just like how you take the fibrin clot, we take inside out sutures and we deliver this synovium into the horizontal tear. And I can show you some MR pictures. We are seeing that heal, and sometimes even in vertical tears, you can see that in this case, there's a bit of fat to here. You can see through the passport, we're delivering the synovium into the tear, and then you can put into the tear, and then we close it again with multiple sutures to enhance healing. You can see some of this MR. You can see this patient here in a white zone. We're done. You can see at 1 week MR, we just kept serially, because these are the early days when we're trying to do, and you could see there is some healing even if you put synovium into the tear. I told you initially we thought we create a vascular synovium by turning the synovial tissue over. Then I realized that when I'm moving it might tear off. And from this paper saying synovial mesenchymal stem cells have the best pluripotent cells, we started using this, and we've done about 6 cases. And we have close to only one of them has failed, we think. And that guy wouldn't come back for a MR or a scopy. He says, I'm not very happy, that's all. Of course, if you have no other option, we started off all these augments, either a collagen meniscal implant, or we have this young boy, which is in ActiveFit. He's very happy. But every time I see him, every 2 years, I do an MRI, this tissue is getting smaller and smaller. So this sort of artificial stuff in meniscus, I don't think it works. And that's when, of course, you'll want to get some sort of a meniscal transplant. This is again a 20-year-old boy had a meniscectomy along with the ACL 1 year down the line. He's come with early wear. And of course, we do in the medial side, do not use bone plugs. It's easier to do without bone plugs on the medial side. You can suture it into the defect. In the lateral side, we do use bone plugs like a trough, because both the roots are too close to each other. If you try two tears along with the ACL, we're going to communicate these tunnels to us. So we use a trough on the lateral side. On the medial side, we use no bone. You can see one of these, we measure, suture this in, and then we populate this both outside and inside with bone marrow cells of the patient to try and heal this. And so far, so good. This is about 18 months. This patient's doing okay. You can see that that's pre-meniscal and that's post. You can see the MRI. There is something here. And then one of the issues we found You can see that MRI shows even the posterior one is that some of these still extrude. This is somewhere in the middle, not in the posterior. And this is where probably I'll use that circumferential stretch next time I have this problem so that I can avoid this, putting the sutures outside in the meniscus and then take it inside the knee when I do a transplant. Now, if you have a focal central defect, that people are starting to use segmental replacement, this is probably a situation where I'm going to use a piece of semi-T or a gracilis to augment that repair and use some sort of tissue here rather than using the entire semi-T as a meniscal transplant. I would use this for smaller segmental defects to bridge the tear and then put sutures around it. That's probably where I use this, or tendons. Now, what will be the future? We have this tech from Japan, which they use synovial mesenchymal stem cells into a gel. We'll see some, people are injecting cells. You can see that they have actually shown in mini pigs putting this gel-like thing into meniscus and getting it healed. So this is maybe what's something going to happen in the next few years, or there'll be better stuff. 3D printed meniscus, but they're very difficult to get them because it keeps changing meniscus. So I'm not sure when you're going to 3D print these and use that into patients, because each zone has different types of tissue. So hopefully newer things are going to come and help us. The new kid in the block is microRNAs. The PRPs are going away because we have a lot of gray areas. Not going away, but they're still being used. But microRNA may be a game changer, both to diagnose as a blood test for arthritis and maybe even meniscal tears, and probably even help healing. So that's the next new kid in the block for guys who are going to start like Vivek and all this with medical college help to go further into it. So what is important when you use augmentation, what is inside your soup is most important. So what you put it right. But one of the gray areas, I don't know how long I have to keep it, the cells there before I start moving it for the cells to adhere, but I'm definitely seeing better results. I'm more aggressive, more confident of my repairs than what I was early in my career. So it's important that you repair them well. We need to augment the repair, and we need to protect the repair. And so we are not just carpenters. We got to be good tailors to retain this meniscus. Thank you. And if you have any questions, I can answer while you guys are there.
Yeah, I guess anybody would like to ask any questions and then talk to you.
There was a lot of controversial stuff I talked.
Yes, certainly.
Yeah.
Sir, I've seen you using a lot of scorpion for taking the bites.
Yep.
So can you tell a little bit more about that? Like, how do you do it? Like, I've never used a scorpion, at least definitely for the meniscal bite.
If I have enough space,
Sure, that's the main.
that's the only time I use scorpion. We use scorpion more at the back. I've had situations early in my career where the tip of the meniscus, tip of the needle has gone into the cartilage.
Yeah.
In fact, a doctor's son, in theater with me, the tip went in and got buried in the cartilage. I went MR, looked down, I couldn't find it, but nothing happened. So definitely only if I have space, I use scorpion. I've just put 2 videos. But recently, of late, I've used 90% of my repairs are inside out. And that's why I think I'm getting great results. I think the all inside stuff do not have the same amount of tightness. And then when you put this big needles in through in this degenerate tears or tears which have been there for long, you make bigger holes. The inside out are small needles. So I think it's a big game changer for me. That's made a big difference for me. Yes.
Thank you, sir.
So Jacob, sir, in the meniscal repair, there are two, theories, not the radial tears, but in the longitudinal tear, especially when you repair, do you allow them full weight bearing with the brace, or you keep them off the weight bearing? Because one of the school of thought says when you allow them full weight bearing, they actually meniscus co-opts well, because of the longitudinal pressure. So
I do not let them weight bear except for a root tears. Root tears I let them, or horizontal tears, but vertical tears, I'm a bit always worried because I don't want fluid to go into my tear. So I keep them off weight bearing 4, sometimes 6 weeks. I know it's not always easy for patients to be non-weight bearing, but I don't, except for root tears. Yes, I let earlier weight bearing and horizontal tears.
The other problem, I also face, I'm not sure how you tackle this. The inside out on the lateral side is a challenge. Because you see, meniscus, when you do the medial side, it's nearly straight, the knee is straight, and it comes out very anatomical. Whereas the lateral, it's in figure of 4, it comes below. So how do you tackle that? Or do you have some, tricks and tips?
My incisions are more below than above because I need to protect the nerve. So I'll make sometimes 2 incisions on the facial lata, so I get space to pull that out. Except for that posterior, it's more or less the same. Sometimes I make bigger incisions on the lateral side because I make sure that I'm not in the nerve, and I put my spoon through the facial lata in front of the nerve. But there's nothing else. And I always make my incision more inferiorly. So when you go figure of 4, it comes out inferiorly, because otherwise it goes up. If you've got the incision more superior, half about the joint line, it tends to go up. So that's the main difference, I think. Yeah. And of course, you want to make sure you don't cast the LCL too. So you want to be in front of it or behind it. So I try to get it all the sutures in front of it, at least when I tie them.
Okay. Okay.
Good evening, sir.
Evening.
Sir, my question is regarding these tight knees. So when it is tight on the medial side, you might probably picrus the medial side and you can open up the medial side. But if you have those knees who have a tight IT band or a tight lateral side, especially the runners and the wrestlers, how do you deal with these tight lateral side knees for
There
repairs?
is no
This,
needling on the lateral side to help us. So
yes,
only option is passing it down. You sometimes can't see as well as on the medial side. The guy outside catches it better. I think it's a bigger issue when I'm trying to repair the tears around the popliteus. So that's an area sometimes sometimes we actually catch onto the popliteus. Sometimes you can't go on either side. So that's where I find more of a problem, where we don't have space. Yes, there is a challenge there, but you keep changing the angle of the knee and try and get some space. There's no other way out. And it's crucial on the lateral side, do not remove the meniscus ever, to me. They heal.
yes,
They heal much better than medial meniscus. So do not remove anything. And if at all you remove keys, put sutures first and then shave with a very little suction so you don't take any tissue out. I've only gone back
yes,
3 or 4 times for failed repairs in the last, from 2016, I've been very aggressive. So that's close to 7, 8 years now. So, 3 or 4 times. So we do close to 100 repairs a year. So, I think there is more to repair than removing it. Of course, you tell the patient clearly, there's a failure rate, but if I remove it, you're going to have it. So I put the onus on the patient, and they say, okay, I don't want to do it. There are guys who want to put the last year of playing. So they said, I need to go back to playing. Then, of course, there's no other option. But otherwise, push it. That's what I think.
Sir, there is a question in the chat box regarding your thoughts on taking popliteus in the bite during lateral meniscus or repair.
I try to avoid it by going at the back. I try to go down behind the popliteus, and the front, I try to go above the popliteus. I try to do that. But sometimes, like you see, when you can't see well on the lateral side, you try and anchor it somewhere, because when they move, the sutures break. Patients tell you sometimes at about 2 months, 3 months, I felt a ping and then I felt better. So I think the sutures break if you go through this thing. So I try to avoid it, but sometimes it goes right through and through. I know that because I can't see very well on the lateral side, just like Nandan just raised the issue. So I'm not too worried about that. It
Great,
breaks.
sir.
Same posterior tears too in the medial meniscus. When you go into a capsule, patient tell you, I felt a ping and I felt better. So probably the sutures will break in time, and then things move on.
Any more questions from the panelists or any other?
When you do this inside out, when you take all the bites, is there any trick to get it properly reduced? Like, do you tie all the sutures at once, or is there any trick to get it better?
What is important is you start each one you pass, you get your assistant to tie it. And you can watch, and so you can see the tension. So sometimes you don't put it so tight. Sometimes when you tighten too much, it rolls up. So you can tell that suture, don't make it tight, keep it tight. So if you see from inside, or you get your assistant to show you from inside when you tie it, so we try and tie each. Of course, there are times where you're busy or you have to run from one to the other, you tie then. But ideally, I would want to watch while you tie it.
So you're tying each suture one after the other, not
one
at
after the other, and
yeah.
watching it, because the second one may be looser or tighter depending on how you fold the meniscus. So that's important. You watch it from so either you or the assistant.
It's the same for both the lateral and medial meniscus.
Side, yes, because it folds up and down. I'm not sure it makes. I was ignoring all this before. then I have a colleague now who keeps correcting me all this and make me do better.
Any more questions for Jacob, sir? Otherwise, I think yes, he's got a flight to catch, and then we can let him off the hook. Yeah.
Thank you. Thank you. And
Thank you, sir. Thank you.
Thank you, Jacob, sir.
Wonderful
Great
presentation.
talk.
Thank you very
bye.
much, sir.
Thank you. Thanks.
Thank you for your excellent presentation. Thank you.
Thank you. Bye. Bye.
Thank you, sir.
Thanks. Bye.
Yeah, I guess
Naresh,
yeah.
Sir,
Naresh, do I have a permission to leave?
sir, please, sir.
I'm extremely apologetic, but this is, we have worked a lot on stem cells. Probably, Manipal
Yes,
has been
yes.
working. So today, some delegation has come just yesterday, and they are meeting today. So it started from 7:30, but I had a commitment with you also. So I just have to go and catch up with them for at least half an hour. So I am,
Go ahead.
maybe
No,
again
no.
you can invite me. I'll catch up again with the IS meeting.
Yeah, sure.
Yes.
Go ahead.
Thank you very much, sir.
Okay. Thank you. Thank you.
Yeah.
Thank you, Harish. Thank you. Bye. Bye. Take care. Bye.
Take care.
Bye.
Okay, we go ahead with the second talk, which is a case presentation by Dr. Nandan Rao, which is on KD3 knee dislocations, two-stage repair with sparing approach. I think Dr. Nandan, you can share your screen right now.
Yes, sir. Good evening, everyone. I would like to thank the IS and the organizers for giving me this opportunity. So this is my case. This is a KD3 knee dislocation. Good evening. I am Dr. Nandan Rao from Unity Hospital, Surat. So this is a 40-year-old male who presented a week after an RTA. He got primary treatment somewhere else. And on examination, he had an ACL, PCL, and an MCL grade 3 instability. He was a chronic epileptic who was well managed on medications. This is his clinical situation. So that is a grade 3 MCL opening with ACL and PCL, which is completely lax. This is the MRI which we got. So the MRI showed a MCL distal avulsion with the substance of the MCL looking quite okay on MRIs. The stir images showing an ACL and a PCL tear. And if you go on to the T1 images, possibly it is a PCL avulsion with good preserved PCL tissue. So this is very important. You go back to the T1 images to see if you have any doubt regarding the ligament status. So I went ahead with the medial approach. So this is the first stage of the surgery. There was a pes anserinus avulsion. The superficial and deep MCL was torn. The knee opened up quite effortlessly, and the PCL remnant was found to be viable and avulsed from the femoral condyle. I could figure out both the bundles of the PCL, take independent sutures through them directly with the needle holder and with the antegrade suture passer used in rotator cuff repairs. It was passed through a transosseous tunnel and then tied over the endobutton. You can see the four limbs of the suture. This is the intraoperative video which shows the superficial MCL. I have taken transosseous pull-through sutures. That is the tone deep MCL. And this is the pes anserinus avulsion, again, which has been repaired with transosseous sutures. So that is the superficial MCL pull-through sutures, which were tied on the lateral cortex using endobutton, and the pes anserinus was also repaired in a similar fashion. This is the post-repair stability. So you can see quite stable in valgus and quite stable on the posterior drawer, and anterior drawer was lax. So this is at post-operative 2 months after the first stage. The MCL has healed quite well. You can even make out the pes anserinus traversing outside the MCL. And the PCL seemed to be well healed also. The range of motion was 0 to 120 degrees. The PCL was grade 1 and the MCL was quite stable. So I went ahead with the second stage. This was an arthroscopic ACL reconstruction. The PCL was found to be very well healed, and the graft for the ACL was the quadruple semitendinosus from the opposite side. Now, unfortunately, I do not have videos of that surgery because it was lost in some technical issues. And this is the patient's follow-up at 3 months after the second stage. So this is, he has full range of movement and good anteroposterior stability, as well as valgus stability also when compared to the opposite side. These are his post-op x-rays. On standing, he was doing quite well. And on valgus stress also, the knee was opening up almost as equal to the normal side. So what does the literature say regarding PCL repairs? That primary repairs heal well. They give near normal objective stability. The subjective results may vary, but proximal avulsions heal better than the distal ones and the mid-substance ones. Augmented repairs can potentially do well, and that is one area where I think I could have improved my surgeries. Regarding MCL repair, the primary repairs again heal very well. They give near normal objective stability. The distal avulsions specifically need repair. The proximal avulsions, if they are undisplaced, they can be conserved, and you have to assess the tissue quality. If in doubt, you have to reinforce either with an autograft or a synthetic one, whichever you prefer. Beware, the systematic review has shown that MCL repairs, the patients end up with a stiff knee more commonly than with the MCL reconstruction. But what we have to take care is the initial stability should be quite well, so that you can start with the range of motions within the first week. Regarding staging, I found one study where everything was managed in one shot, the ACL, PCL, MCL. There is evidence for single stage surgery and two stage surgeries. I prefer to do two stage surgeries. Finally, what I would like to convey is you have to identify and try to preserve the tissues. In this case, the pes MCL, PCL was repaired. The repair gave initial stability for the range of motion. So I started with the range of motion after the first week of the first stage of surgery with CPM. And that is what I think gives that extra edge to us. If we are able to achieve good stability at the end of our first stage, we can start with the range of motion early and probably end up with a good result. All the three things healed and decreased morbidity and complexity of the second stage. The other advantage is if you find that the MCL is or the PCL has become lax after the first stage, they may be reinforced at a later stage if needed, and it will require a lesser diameter autograft. Preservation of anatomy leads to good outcomes. Thank you.
Yeah, that's a good case. And Dr. Nandan, your
Yes, sir.
modus of operandi was really good because the MCL repair being repaired, especially that's the take-home message that you have a distal avulsion of the MCL that needs to be addressed,
Yes.
and
Yes.
then the mid-substance or the proximal ones. So once you do that, your knee gets a stability, like you're able to get a good range of motions, and then you can address your PCL and MCL. You got lucky with the PCL. The PCL is good as an avulsion
Yes.
kind of injury, so it healed.
Yes.
But
Yes.
in case you had a PCL full-blown tear also, would you go through the
Yes,
same
sir. Yes, sir.
modus?
Yes, yes. So, yes, sir. So I have managed a few cases. So where I have done only the MCL and protected the patient and done CPM. I do not allow for active assisted range of motion so that the tibia does not, sag out every time. I protect the knee in a knee ROM brace, start with the CPM, get to around 90 or 100 degrees, and then do an early reconstruction of the ACL and PCL.
Now, my question was in case if you had a PCL full-blown tear without the avulsion part that you had a full-blown
Yes,
mid-substance
sir. Yes, sir.
PCL, and with the
Yes,
MCL,
sir.
would it be a great idea to do the MCL as well as the PCL in the same sitting and then think about doing the ACL again? Just asking.
Yes, sir. So that yes, sir. Yes, sir. That is definitely an option. I am not comfortable that
Yeah,
much doing the PCL in the first stage itself because somehow I'm not very comfortable, and I've been managing it for a quite a few cases I have managed in such a way. They found that that suits me very well. But yes, the doing the PCL and the MCL is definitely an important part of doing it.
And also the other thing is that probably the audience needs to know that if you have an isolated PCL tear, you shouldn't jump into reconstruction of the PCL because PCL's blood supply is quite good, so chances of healing also is quite good.
Yes,
So that's
yes,
the other point
yes,
that's taken for. Okay.
yes, yes, sir. So the study I presented, they have compared the conservative management along with PCL repairs, and what they have found out, although the objective stability may not be as good, but patients, there is a big NHS study which says this thing also, that PCL, if they are conserved, although the objective stability may not be that good, but patients never complain of anything, and that is quite 8 or 10 year long follow-up which they have.
Yes, yes, sure.
But modern medicine and the what you might say, the demands of the patient have dictated that in recent times we end up with doing more of PCL reconstructions than what was being done probably 20 years back.
I do agree on that. Yeah. Any other questions from the audience, or can we move on? Naresh, anything else that you want to put in?
No, sir. Any other panelist, please ask, can ask questions.
Nandan said that was a very nice case. Recently, we also had the similar cases, but when do you choose to conserve your MCL? You said like, especially if it is from the femoral side, we
Yes,
sometimes we can conserve. Even if it is a part of a multi-ligamentous injury, because like, once I had a femoral from MCL avulsion from the femoral side and also ACL and PCL, and I went in and did after 3 weeks ACL and PCL. And after about 3 months, I still felt the MCL was a little lax, even if it is from the femoral side. And we had to augment that side of the MCL as well. So, what is your take on that, sir?
so I believe in a very few things. So the first thing is, in addition to MCL, if you have an ACL or a PCL, you first look where the MCL is stored. So if it's a mixed substance, you have no choice, you have to
Yeah.
reconstruct. If it is a distal avulsion or a proximal avulsion, you repair it. See, you are going to operate the patient. You do not get any brownie points for not managing the MCL while doing the other ligaments.
Yeah.
So if you are conserving the patient altogether, then it is agreed.
That's right.
But if you are operating for an ACL and you are not touching the MCL, when you know it has avulsed from the femoral side or from the tibial side, I think that should not be done. If you repair it and after a period of time it becomes lax, then you can always go in and reconstruct. But you are not touching it when you are operating your ACLs. I think it should not be done. That is one thing. Multi ligaments, you have to be a little more aggressive. So if your ACL PCL is gone along with MCL, you have to be more aggressive in operating the MCL. If you have an ACL with an MCL and you have a femoral avulsion, what you can do is you can simply, do a clinical examination under anesthesia. If the ligament laxity is 1 or 2, grade 2, then probably you, even if you don't want to repair the MCL, that is okay. And it is a femoral avulsion, you can conserve it. But a grade 3 opening, femoral avulsion with an ACL, you have to repair the femoral avulsion. You don't get any brownie points for not managing it.
Yeah, absolutely, sir. Point well taken. That's what we have burnt our hands in one of the cases by doing that. But
Yes.
okay, thank you. Yeah.
Yeah. Thank you. Thank you.
Right.
Naresh, we'll move ahead with the third
Yes,
talk.
sir. Please, we can go on to the next talk, sir.
Yeah, and the next case presentation is by Dr. Hari Prakash on all inside physical sparing ACL. Dr. Hari, you can share your screen.
Can you see it, sir?
Yes, yes, we are able to see it, sir.
Yeah.
Sure. Thank you very much, sir. Thank you for giving me this opportunity. I would like to especially thank Naresh, who has been a very close friend of mine from my medical college days. I would like to thank him and also Harish, sir, and Vivek, sir, and also the entire IAS team. Thank you very much. My name is Dr. Hari Prakash. I'm an orthopedic surgeon working at KIMS Hospital in Hyderabad. So today I'm going to talk about the pediatric ACL reconstruction. So we all know from the history that pediatric ligaments are actually much stronger than the bones. So whenever there is an injury expected in a pediatric age group, it's either mostly from the bony side, very less from the ligament side. It's either a tibial spine or a physis. And because the growth plate is a weak link, especially in the complete mid-substance tears in ACL are very, very rare in case of a pediatric age group. So why are we seeing these pediatric age ACL injuries more commonly these days? It can be related to the greater number of children who are participating mostly in organized sports. We all have played the backdoor sports, but since the more children are engaging in organized sports, we are seeing more pediatric ACL injuries, and also increased recognition in the medical community. And we have now better methods for diagnosing these ACL injuries. So coming back to the basics, what is the basic functions of ACL? It's like it resists the anterior translation of tibia at about 30 degrees of flexion. It prevents the hyperextension. It also acts as a secondary restraint to the to internal rotation of tibia, and it also in full extension it also prevents the AD and abduction. So if you see the anatomy, we know the most of the growth happens mostly around the distal femur or the proximal tibia. So sparing the physis is very, very important, especially in pediatric ACLs, or else it can lead to what we call a multiple different kind of deformities. Most commonly, what we see is a limb length discrepancy, or we can see an angular deformities, especially while if we breach the femoral physis while making a femoral tunnel, or while if we're doing a tibial tunnel, if we breach the tibial physis, most commonly what we see is a recombinant deformity. So when you have a acute injury of the knee, it presents in different age groups. The commonest injuries are a little different. In the age group of around 7 to 12 years, ACL injuries are more common, and ACL and meniscal injuries are about 47%. Surprisingly, we see a high number of osteochondral injuries also in this age group. In adolescents, the ACL injuries are more common compared to the meniscal, and osteochondral injuries are quite less. And so what are the different options of treatment we have when you have this kind of a pediatric ACL tears? So usually we can either conserve them, or we can do a primary ACL repair depending upon where the tear is. And what we can do a spatial sparing reconstruction. We can do a partial fascial sparing reconstruction or a transfascial reconstruction. So there is enough data now in that which are published, which says if we delay the ACL repairs in the pediatric age group, especially in the pediatric age group, it leads to secondary meniscal tears and also osteochondral defects. This is the one paper which is presented in 2013, which they studied about 217 patients, and they said like 12 times more risk of having a medial meniscal tear with non-operative treatment. This is another paper which is published recently in 2021, which also again says there is high chance, this is a meta-analysis actually, which says high chance of meniscal injuries and osteochondral injuries. They studied a large group of patients of about 1,176 patients. And there is another paper from PubMed, which is presented in 2016. So all these patients now suggest of going for a ACL reconstruction even in the pediatric age group. Before we had the thought of having conserving them initially, and till the time there is the adult stage, and doing an adult ACL reconstruction, which is quite easy. So what is the things that we need to keep in mind when we are doing a pediatric ACL reconstruction? It is the skeletal age, which is very, very important, and it can vary from gender wise in boys and girls as well. So usually if they're in the pre-puberty age, usually we classify, we take the age of a boy less than 13 and the girls less than 12, we take them as pre-puberty. We can go for a complete fascial sparing. If they are about puberty age, about 13 to 16 in boys and about 12 to 14, we can do a fascial sparing on the femoral side and transfascial on the tibial side. If they are more than 16 or 14 in girls, we can directly do an adult type of a reconstruction. So if depending upon how much of the growth is remaining, we choose our technique. If it is about 1 year of our skeletal growth is remaining, we can completely do a adult type of a ACL reconstruction. If there is about 2 to 3 years of growth remaining, we can do a partial transfascial, wherein femoral we are sparing and tibia we are going transfascial. If there is more than 3 to 6 years of skeletal growth remaining, we have to do what is called an all fascial, wherein we are sparing both the physes. So this is a small video that I wanted to present. This is again regular diagnostic scopy looking at the medial and the lateral gutters there, and looking at the medial meniscus there again, and the lateral meniscus there. I found a small tear on the posterior side of the posterior horn of the lateral meniscus, but I found it very stable and it was not propagating through and through. It was not seen on the inferior side. So we have decided it has to be a stable tear, and we haven't repaired it, assuming we are doing an ACL and it would heal on its own. So once we have done our routine diagnostic scopia and checked for the meniscus, and we have decided that we are not going to do anything for the meniscus, we have harvested our hamstring graft, only semi-T graft, and we started preparing for our ACL reconstruction. That's preparing for our, that's like, shaving the stump and, sorry, shaving the tibial and the femoral stump. And here we are using a zig and we are drilling it from outside in. And while doing this step, we use take the help of a CM, and we make sure we are not crossing violating the physis there. And this is done with the help of a flip cutter that is now commercially available in quite a few companies, wherein we can drill the tunnel of necessary size. So that's how we do the femoral tunnel, and that's our position. We mark where the physis is, and then we use the CM, and that's how we can drill from inside out. Once the femoral tunnel is done, we check, we make sure we have thoroughly shaved it off and properly making sure the tunnel, we have not breached any kind of any cortex there. And then we come to the tibial tunnel. After doing the suture management, we come to the tibial tunnel, wherein again, we are doing it all inside. Here, since my patient was about 14 years of age, I've chosen to go transphysial in case of a tibia. Again, the flip cutter is used to make the tunnel. And once both the tunnels are done, we have passed the graft. And passing of the graft along with the with the endoperton and the tibial, femoral and the tibial side, it's the routine same technique that we follow for the adult there. That's the graft, and we flipped it onto the tibial side, and that's the final position of the graft on both the tibia and the femoral side. And that's how the CM CM image that we have looked, and nice good graft. Found it little lax, and we finally tensioned it more. Thank you.
Yeah, Hari, good talk. What's the size of the graft that you normally get in a pediatric group?
So this patient was about 14 years, sir. So we have got about 8 and 8.5, 8 on the femoral side and 8.5 on the tibial side. So again, it depends, like, some patients who are a little bulkier and, like, who are into sports, they usually tend to have a good graft. But if the graft is not sufficient, I don't hesitate to take even the gracilis as well. Here in this case, I have taken only the semi-T because I felt I was getting about 8 and 8.5. So I felt that was enough for me.
If you look at those pediatric orthopedic surgeons, they usually vouch saying that 8 mm is too thick a graft.
Yes.
And you'll have to use an 8 mm, reamer, and so the chance of the physis getting damaged is very high.
Yes, sir.
You usually prefer your take on that.
Sir, again, I've seen quite a few pediatric orthopedic surgeons do the ACL, especially from the HSS. They say like about 8 mm is fine. Beyond that, that is where they start having the complications, like you have mentioned, the physeal damage. They say the maximum limit is about 8, especially if you are doing a physeal sparing. Since I got a 8 mm on the femoral side where I was doing a physeal sparing, I was okay with it. And anyways, I was going through a transphyseal and tibial side, so it was about 8.5. So I was okay with this in this case, actually.
Okay. Now the whole concept has changed. I mean, you're absolutely right and bang on. Probably this topic also was mandatory that you need to do your ACLs in the pediatric group. You need to do it. There's no
Yes, sir.
doubt about it. You can't treat them conservatively and expect them to come back with a meniscal injury or a osteochondral injury. That's the point.
Especially people now going into complete full-time sports. That's where they get likely to get injured. And treating them conservatively or waiting till they become an adult is ruining their career, actually.
Yeah, apart from being the carrier, it's actually very difficult to keep youngsters in that age group from not getting into activities
Exactly.
kind of thing. Yeah, I mean, yeah,
Absolutely, sir.
very
Yes.
active. So
Yeah.
it's very difficult. Any questions from the house? Nandan, you have any question?
Dr. Hari Prakash, very nice presentation.
Thank you,
So,
sir.
what are the fixation options you have used proximally and distally? How have you fixed the graft?
Yeah, it's the endo-button, sir. It's a all-inside technique that we use, like we use for the adults. It's the same endo-button that we use, which can be tightened.
The fixed loop or the adjustable loop?
Adjustable. It's adjustable on both the sides.
Adjustable on both
Yes.
the sides.
Yes. Yeah.
Okay.
Yeah, it's like the all inside ACL.
It's
Yes.
all inside ACL.
Okay.
Yeah.
You can also use staples, the small
Yes.
staples which are available, and they can use that also as another possibility of
Yes.
Sir, what is your take on adding an extra lateral procedure in case of a pediatric ACL or pediatric
I
reconstruction?
believe LET procedures, especially in pediatrics, is just an overkill. It's too much of
Exactly.
yeah,
So
exactly.
it gives too much of a tightness.
Absolutely.
Yeah. Mm.
And you've seen that, okay, I do agree that in revision scenarios, yes, I agree, possibly, yes.
And
But for a
surprisingly,
primary scenario,
sir, sorry.
sorry, primary scenario, I'm not a great fan of doing all LETs for primary scenario. There's too much of
Right, sir.
constraint, especially in the lateral compartment.
Surprisingly, if you see in pediatric age group, the pivot shift is much lesser than compared to the adults, sir. So I don't know the reason, to be honest, but the pivot shift, which we call grade 3 pivot shift, is most where we are doing the LETs, is much less in pediatric age group.
Yes, absolutely, absolutely. I do agree with that. I think it's got a very clear indication that you have a grade 3 pivot or you have a revision ACL scenarios. That's when the LET comes into play. Yes.
Sir, one more doubt.
Sure.
If you have a pediatric patient with the ligament laxity, real ligament laxity, what would be the graft size? Would you do a BTB or still stick with the hamstrings?
Again, I don't have an experience of doing a BTP at pediatrics, sir. This is very new to me also. We have only very small sample size, about 4 or 5 cases now of different age groups. The youngest we have done was about 8 years. And more or less it's in that age group. So in most of the cases we have used hamstring. We don't have any experience of using a BTP in pediatric age group. As sir said, the size of the tunnel and the diameter of the graft is very, very important, especially when you are sparing the physis. So when you are doing a BTB, usually we tend to get a higher size. In hamstrings, at least we can manage the size of the graft. We get into in our limits. It's because it's more or less within our hands. So we have always used a hamstring so far, but again, as I said, no experience with BTB. I would still go for a hamstring.
What
I
is
think
the
a
Hari,
soft
sir.
tissue graft, a soft tissue graft is a better option
Yes, sir.
than a bone graft. Yeah.
Yeah.
Hari, sir, what is your take on laxity after ACL reconstruction in case of pediatric population?
Again, after see, again, we don't have a big follow-up now so far. It's been just about maybe about 4 to 6 months of the all the cases that we have done. There, after any ACL reconstruction, we will have minimal laxity for sure, about a grade 1 laxity. I myself had an ACL tear. I had a reconstruction. I still have a grade 1 laxity. So, but one thing that we have observed is they are able to perform well in sports to their level, which they have been doing before the surgery. So I'm assuming that it is not much lax and they're able to do the sports. And it all depends upon how well they do their physio. That takes a major role in having how much laxity you will end up after ACL reconstruction.
Yeah, I mean, when you discuss the options with the patient and the parents, you will tell them that the idea of doing the ACL reconstruction in this group is just to make sure that he sails through his
Yes.
uh,
True.
age till he is about 18, so it doesn't make sure there's no injuries to the meniscus and the osteochondral damages. And if at all he has a re-rupture sometime later, probably you can do a normal ACL reconstruction and get away with that.
I have another doubt in this pediatric, sir. I would like to ask Harish, sir. So we are putting this femoral tunnel now more horizontal than what we do in adults because of the physical spirit. Would that affect the, as you said, re-tear or, anything?
No, I've done pediatric ACL reconstructions, the facial sparing ones, and I've never had a problem. I mean, yeah, I do agree with your thought. It's really concerning, but
Right.
never had an issue about it. I've had players playing cross, and they some of them still hold good. They've got 18, 19, 20 years and still hold good, and they just having their game. Yeah, it's there.
Because like traditionally also we have come from a more vertical tunnel to a horizontal tunnel.
Yeah,
So
yeah.
is this making more horizontal better or is it bad? I'm not sure still.
Yeah, probably the percentage of the ACL in the pediatric group also is less compared to what we do in adults. So yeah, so maybe in centers where they do pediatric ACLs on a regular basis, or they'll be able to give us a better answer on that.
Thank you, sir.
Okay, great talk today from all the three speakers. I think Jacob sir's talk was excellent, and also Nandan's case was good. Same with Hari's case too. So we've had a good time spending cross and meeting as well as discussing a lot of issues. So Naresh, we'll wind
Yes,
up
sir.
for
We
today.
can. Yes, sir. Yes, sir.
And we
Thank you,
hope
sir.
to catch up sometime for the next IS
Yes,
second next month. Yeah.
Yeah.
Sure.
Yes.
Thank you very much, sir. Thank you very
Thank
much
you,
for
sir.
joining.
Thank you, Harish, sir, for your time.
Pleasure to meet all of
Thank
you.
you, everyone.